there's a couple situations where it can increase. Statins actually do increase lipoprotein(a). Interestingly, on average around 19%, some people more, some people less. So it's good to know. And then also the menopausal transition is cruel for many reasons. Anybody who says that that's fair, no, it's not. But one of the things that can happen in the menopausal transition is that lipoprotein(a) can go up quite a bit, just because estrogen suppresses the basal production rate of lipoprotein(a). When that is lost, then your true LP(a) colors show. So that's why it says at least once in a lifetime. And then hopefully on the horizon there will be therapeutics specifically targeting lipoprotein(a) that can help people. And then you can actually track what your level was and what it is now after receiving a specific therapeutic, if those felons have been causing mischief in your arterial wall. And this lipoprotein(a), we can go into the why it's so bad more or not. I mean, but what I'll tell you is it's an independent risk factor, meaning you can have virtually a perfect home security system, and if you have a high lipoprotein(a), you can get broken into. So this is one of my best friends. He's an example of this. So this guy, I mean, he's super fit. No hypertension, no insulin resistance, even by the Josh advanced metrics, all the sophisticated, NMRs. No insulin resistance, no hypertension. HSCRP is a common marker of systemic inflammation. His was like 0.4. I mean, it was no inflammation. And then he has never, touched a hard drug or smoked or anything. So this guy, he's super fit. Lifts, runs. I mean, the guy just looks like he descended from Mount Olympus, but his family history is no good. And we're out on a run, and I'm one of those guys who's, super obnoxious to run with because I never shut up the whole time, which probably isn't shocking to you guys after, just experiencing this deluge this morning, or this evening in India. But anyway, so, we're talking on this run and he's telling me about his family history and all this family history of cardiovascular events. I'm like, dang, man, that's no good. And so I told him, hey, get your lipoprotein(a) checked and get a CAC, this colonoscopy of the heart without the nasty pregame show. Well, his lipoprotein(a) was 128 milligrams per deciliter. The preferred measurement's nanomoles per liter because it's particles. And once again, particles dictate risk. But 128 is quite high. Anything over 30 to 50 is intermediate. Anything over 50 is like really high with milligrams per deciliter. He's at 128. So he's really high. And he gets his CAC back. 2,814 was his coronary artery calcium score. So if someone has a score of 300, that has equivalent risk of you having a cardiovascular event as people who have had prior myocardial infarctions. And so those are the highest risk people. They've already been broken into, and the greatest likelihood of you getting broken into is if you've had it before. 2,814. No symptoms, because he's super fit, right? And he actually had to have a 5-vessel CABG, a coronary artery bypass graft, earlier this year. But his 10-year risk calculator, which is how a lot of clinicians operate, they're like, oh, your 10-year risk calculator is 2%, which it was. His was 2.3%, and his standard measurements looked amazing. And they said, don't do anything, and his LDL cholesterol was like 110 maybe. So nothing that would be like a red flag, especially how fit he is. And it was the lipoprotein(a). So that's why I encourage people to get that checked. And also get a CAC. Got plaque? You don't know. Get a CAC, right? And so that we can shift the paradigm from reactionary to prevention, because who knows? He may not even be here anymore if he hadn't had that stuff done. So that's why I encourage people to get the lipoprotein(a) and get a CAC. CAC isn't as useful in a younger person because it takes time for these things to transpire. But the power of non-zero in somebody, say, under 40 is still significant because, oh man, you've been broken into early. Let's get ahead of the game. So I'm a big fan of the imaging tests that tell us if disease is present in combination with what we can understand based on our lipid metrics. And so I encourage people, hey, get your basic lipid panel and get a lipoprotein(a). If you can get an ApoB, great, but there are really two situations where outside of rare lipid disorders, that ApoB is going to be discordantly high based on, what we see on your lipid panel, and it would be insulin resistance and elevated lipoprotein(a). So if you can get an ApoB, I'm all for ApoB. It is a great test, and then you can kind of actually do a guesstimate, a pretty good one actually, of if you have small dense LDL particles based on your LDL-C to ApoB ratio, and so so you can get a lot with an ApoB. In a perfect world, we could get all the things we always wanted, and you can get some nerd to tell you what it all means, and then carry on with your life. But in a non-insulin resistant person without elevated lipoprotein little a, I mean, for myself, right? Do I even tack on an ApoB regularly? No, because I carry on. I'm such a boring guy. I mean, I try to sound interesting, I think, but as far as my day-to-day life, I mean, I eat the same thing pretty much every day. I, haven't changed. I mean, heavyweights aren't going to pick themselves up. And then, I run around and I pull the levers that I think are necessary across the lifespan for maintaining the optimal metabolic milieu. And so is it going to radically change? Not really. And so, when I go to my primary care physician every year, and I don't have elevated lipoprotein little a, praise God. So do I have him tack on the advanced stuff? Every few years, just for kicks and giggles, because I'm a nerd and I like talking about it. But does it ever change? No. So yeah, that's the deal. Just whatever you're doing, be consistent about it. The best diet is consistency. The best exercise regimen is what you'll keep doing. And then making sure you're sleeping, because sleeping is of critical importance, because you're just spinning your wheels if you're not getting adequate sleep. And, this is pretty, people are like, oh man, that's not what I wanted to hear. Sleep, don't eat crap and move. What does this guy know? Well, that's the answer, every day for the rest of your life. And, that's really what it boils down to. But hey, you don't know, not knowing doesn't make stuff go away, right? If you have a polyp, if you go in and for your colonoscopy and you have a polyp or two, does the guy just say, okay, well, you got a couple polyps, let's wait around for you to get colon cancer, and then maybe we'll do something about it? No, they take them out, and then you carry on. You check back in a few years and, see what's going on, right? So that's my approach with coronary artery calcium scoring. At age 40, and you can get them younger, but it's the standard across the board. I'm like, hey, at age 40, get your first CAC, fire up a 0, check back in 5 years, so that's kind of it. It's like a colonoscopy. And then, if this is non-zero, then we probably ought to talk about how to move you to a safer lipid neighborhood, because you've been broken into and your current neighborhood is a little rough. So I think it gives you a lot of really useful information. Like I said, it doesn't tell the whole story. If you can get a, more sophisticated CT angiography, sometimes plaque actually starts in the iliofemoral arteries. There's a study called PESA where 44% of atherosclerosis started in the iliofemoral arteries. You can get a carotid IMT with plaque assessment if you have a skilled sonographer who does that and identify some carotid plaque, because atherosclerosis can start in different arterial beds. But hey, there's lots of options. But at the end of the day, regardless, we want to be shifting our paradigm from reactionary to prevention. And we have some pretty good ways to do that with our imaging tests and by making better sense of the home security system and the lipid neighborhood that we're living in.